casualty registrars working in Basildon University Hospital, which comes under Mid and South Essex, NHS. Today, I'm here to discuss about our experience, which we dealt in our unit, which led to a successful outcome. Introduction. I'm here to discuss about a monoamniotic twin pregnancy, which was discordant for anencephaly. Monoamniotic twin pregnancy is a rare occurrence occurring in only 1% of all twin pregnancies, or in other words, 1 in 10,000 pregnancies. The discordance of one twin having anencephaly is even rarer, with estimated occurrence of 1 in 5 to 400 million live births. This condition is called MADDA, which is nothing but monoamniotic twin pregnancy discordant for anencephaly. It presents unique challenges due to the management of this condition, because it is associated with increased risk for both the normal twin as well as the twin with the anencephaly. Moving on to the case presentation, we had a 26-year-old primary gravida who conceived after first cycle of ovulation induction with clomiphene citrate and intrauterine insemination in view of male factor infertility. She was referred to us with anomaly scan at 21 weeks and 2 days and was diagnosed to have MCMA twin, with one twin having anencephaly and the other twin being normal without any congenital anomalies. The single deep vertical pocket was 8 centimeter with growth discordancy between the twins. The couple were counseled about the condition, and the discussion regarding selective fetal cord occlusion was also done, and the risks were also explained in detail, including the sudden fetal demise of the other twin. The couple declined the selected reduction as they were committed to this pregnancy, and they opted for expectant management. Antenatal fetal monitoring was done every 2 weeks for the fetal growth, amniotic fluid levels, and fetal growth discordance. Patient was diagnosed with GDM at 28 weeks and was started on metformin and insulin. She received 2 doses of prophylactic steroids at 30 weeks of gestation. A planned cesarean section was done at 34 weeks. The first twin weighed 2.1 kilos at birth and was normal without any anomalies. The second twin, which weighed 1.4 kilos, was anencephalic and had cleft lip and palate. It succumbed to death at 22 hours of life. Postnatal investigation of the healthy twin, including ultrasound brain and abdomen and echo, was all normal. The baby was discharged home in good condition after 4 days. The baby was followed up at 6 weeks of life, and the baby was doing well. This is a picture showing the anencephalic twin, which we had. Discussion. There is an increased risk of congenital malformations in twin pregnancies, basically in twin pregnancies, 2 to 3-fold increased risk. And the risk is mainly due to monozygotic twinning. The risk of perinatal mortality in monozygotic twins alone is 47%. The major causes are twin-to-twin transfusion syndrome, twin arterial reverse perfusion, congenital anomalies, cord entanglement, prematurity, and fetal growth restriction. Anencephaly is a neural tube defect and results from the failure of closure of the neural tube at the base of the skull and is usually diagnosed during the first trimester. Monoamniotic twins can be concordant or discordant for anencephaly. Concordant in the sense both the twins can be having anencephaly, or discordant, like in our case where one twin is completely normal and the other twin has an anencephaly. Discordance has been reported very scarcely. Overall, as per the statistics, this is the 9th or 10th case reported until now. And this stresses the need for evaluating the other causes of anencephaly, that are the non-genetic causes like the environmental, nutritional, ethnic, or use of certain medications. Obstetric complications. The most common obstetric problem associated with anencephaly is polyhydramnios, which has been reported in 80% of cases with MADDA. This is mainly due to lack of fetal swallowing reflex, but the presence of other healthy twin with normal swallowing reflex can moderate this risk, mainly due to absence of intertwin membrane, because of which most of the cases reported until now, none required amnio reduction. The other major issue in monoamniotic twins is prematurity. It can be spontaneous or iatrogenic. Cord entanglement is a common major issue in monoamniotic twins, and the presence of polyhydramnios may further increase that risk. Because of this, selective umbilical cord occlusion has been suggested by some authors. The use of an NSAID called Cilindac was advocated for improving the outcomes in monoamniotic twins, but the practice of using the NSAID Cilindac is currently obsolete now. Management. Termination of the pregnancy on the whole or expectant management, like our case, can be done. Selective termination of feticide using cord ligation, cord vessel occlusion or coagulation, like YAG laser or monopolar or bipolar cautery or radiofrequency ablation or ultrasonic cord transection or hysterectomy and thrombogenic coils. The literature on the selective feticide of monoamniotic twin discordant with major congenital anomaly is very, very limited, and there was only one such reported case. And in that case, unfortunately, both the twins succumbed to death. Expectant management involves frequent fetal surveillance by continuous CTG monitoring, computerized CTG monitoring, serial monitoring of fetal growth, amniotic fluid level, umbilical artery Dopplers. Delivery should be always planned at a tertiary unit after a course of antenatal steroids with facilities to manage preterm unit. Conclusion. Expectant management is a feasible option in monoamniotic twins with discordant anomalies and has a successful outcome for the normal twin when compared to MCDA twins because of closer and frequent monitoring, earlier delivery, and the absence of intertwin membrane, which reduces the risk of polyhydramnios. This form of expectant management can also give rise to healthy organs for organ donation from the anencephalic twin. This report also suggests that there are multiple other causes of anencephaly apart from the genetic cause. These are the references from where I gathered all the information. Any questions?